just remember delirium is always secondary to another condition. We talked about that. And also that it's acute, it comes on fast, and it's second, as I said, it's secondary to other conditions, so it could be a UTI causing delirium, which remember that is very common with the elderly, or surgery. And if the underlying cause is treated, delirium will resolve. If it doesn't, it's not delirium. So in other words, if somebody has Parkinson's or Alzheimer's or another type of dementia, will they have a diagnosis of delirium?
Probably not.
No, technically they can't because they have dementia. They don't have delirium because theirs is not going to resolve. Okay? And it's more common in the elderly. So can it be in children?
Yes.
Yes, but elderly is the most common. And that could be with surgery because of the anesthesia, UTI, so it's more common in the hospital with older adults. And again, it's always secondary to another condition. Okay, and then when you're dealing with people with delirium, do you remember we talked about that you should always call them by their name when you're in the room every time you speak to them, even though you might have been in there 5 minutes, but just to sort of help reorient them. And if they have anything they need to use, like false teeth, glasses, hearing aids, you need to make sure they have those because that's going to enable them to at least get along better. So, and then there's 4 things with implementing. There's 4 main ideas. You always call them by their name. Your face-to-face contact with them, unlike Alzheimer's. You use brief statements, brief, short, concrete phrases, not these long, drawn-out explanations. And again, they're hearing aid, glasses, head a bit up. So that stands out different from schizophrenia because with schizophrenia, you shouldn't be face-to-face or close, where with delirium, yes. So be sure and read over those interventions for delirium. We talked about speak slowly, short, simple phrases. Also, do you remember I was talking about the sitters? If you need a sitter in there, why would you have a trained sitter other than family? Right. The trained sitters, they're trained to deal with people with delirium where a family wouldn't be. Family can be in there, however, the trained sitter would need to be in. So you wouldn't want to have the family responsible. And that's all in your PowerPoints. When assessing a patient suspected for delirium, would you expect to find that the patient's symptoms developed over a period of hours to days, weeks to months, or during middle age? Hours to days, right. Okay. So, and a patient already diagnosed with some sort of cognitive disorder will not have delirium. Okay, so now we're up to where we left off with mild cognitive impairment. I think we got past that, but so I'm at mild cognitive impairment. So this is when people have mild impairments, but it's not people with dementia. So they may have just a slight amount of vascular changes, but they still get along fine and it's not really noticeable. However, neurocognitive disorder. It is noticeable and it develops more slowly than delirium. So primary dementia has no known cause or cure, unlike delirium. And I believe we talked about the different ones I mentioned, Creutzfeldt-Jakob, where the prions in the meat make the brain kind of just turn to mush. So with mild cognitive impairment, there's, of course, memory impairments is the main symptom. It does not interfere with their general cognitive functioning. And it doesn't interfere with socialization or their activities of daily living. But mild dementia is more than one cognitive domain that's affected, and it does interfere with daily life. So there's a significant decline in their previous cognitive abilities with learning, memory, language, social. No change in consciousness, though. So majority of dementias are irreversible because they're related to primary encephalopathy of the brain. Now, when we get to the major neurocognitive disorder, Alzheimer's, because it's the primary diagnosis for dementia, everything in this section will be related to Alzheimer's dementia, even though there are other types like vascular. So the risk factor here is age and being a female. And I want to point out, so the incidence doubles after age 65. So I do want to point out, though, about when they talk about risk factors. In fundamentals, did you ever talk about modifiable risk factors? Modifiable? Okay. NCLEX and ATI love modifiable risk factors. So when we talk about Alzheimer's, some of the risk factors are physical inactivity, depression, smoking, midlife hypertension, diabetes, cardiovascular disease, reduced education, severe head injury, and a first-degree relative. So one of these would be modifiable. Smoking, right. Smoking.
You can exercise.
Right. Physical inactivity, that's modifiable. So you should be familiar with modifiable risk factors. And I believe those risk factors are on page 279. But again, don't scramble to find them because then you're going to miss what's going on. So just make a note and we'll move on.
Sorry, what page did you say?
279. So genetics play a role. Late onset of Alzheimer's doesn't really have an inheritance pattern. However, early does, between age 30 and 60. And that's because of the amyloid precursor protein. So primary is irreversible, progressive, not secondary to any other disease. And secondary is a result of some other pathological process, say like AIDS. So 60 to 90% of all dementias are Alzheimer. It's the sixth leading cause of death. And here are the average lifetime risk. As you can see, it raises once over 65, it continues to increase the risk. So a little bit of cultural information here. African American older adults are twice as likely. Hispanic American older adults 1.5 times. Also, when that's coupled with hypertension, cardiovascular disease, and diabetes, but it's not affected by ethnicity and as far as behaviors go. So attitudes, cultural attitudes, Native American cultures seem to be more accepting of their family and friends, whereas white populations, according to your book, don't have as much patience. They might be a little bit more impatient, irritated with them, or they might feel guilty that they can't do anything about it. Okay, so this tells just a little bit about how it affects, of course, it affects the neurons, it affects communication, and that is because of a tau protein, which protects the microtubules, but with Alzheimer's, it's all disintegrated, and then they get tangles. And things just aren't going to be working well because their communication pathways are no longer working as they should. So brain atrophy can be seen on scans and MRIs.
I dropped my laptop, sorry.
Pardon?
I dropped my laptop, so it's making noise for a second.
Oh, okay. You dropped it? That's not good.
Right.
Okay, so now, here's some behaviors. Early, when patients start to find out that they are realizing sometimes they don't realize, but when they do realize they're having some problems, they might try to hide that with denial. And you want to take note here of confabulation and perseveration. Confabulation is making up stories or answers to help their self-esteem when they don't remember. And perseveration is repetitive phrases or behavior that gets worse under stress. So they also avoid answering questions because then they get upset and frustrated, and so then they just keep repeating. So these are all defense behaviors. So be familiar with those. Now, also, we want to look at the 4 A's of dementia: amnesia, aphasia, apraxia, and agnosia. So be familiar with these terms, and they're on page 280. So aphasia is loss of language ability, apraxia, loss of purposeful movement, and agnosia, loss of ability to recognize an object. Like in your mental status exams at River Oaks, part of it was to say hold up a pencil or a watch or any object if they can't recognize that object. So that's agnosia. So they're on page 280, and know those defense mechanisms. Okay, so now we have stages of Alzheimer's: stage 1, 2, 3, and 4. These are on page 280, 281, and 282, and there's a table 18.4. So they describe what's in each stage, and you'll want to know those. So stage 1 is forgetfulness, possibly some depression, but not real noticeable at first. Stage 2 would be the one that's more noticeable, but yet they can still function a little. So there might be, with stage 2, there could be confusion. They might have some memory gaps, but then they might seem okay at other times. Self-care deficits, apraxia, which is loss of purposeful movement, and they might be labile, mood swings from one end to the other. So then stage 3, moderate to severe, is more advanced, and then the end stage. So with moderate, that's when the deterioration becomes evident. But with moderate to severe, that's when they need total care. So, I'm not sure the book says it, but to best of my knowledge, moderate is the longer stage, but I'm not positive about that. But that's the one, just know those and know that with a moderate, that's when it starts to become evident, but they don't need total care. And then tests for dementia. Well, there's other orders that can mimic that, so you need to rule out drug toxicity, metabolic disorder, nutritional deficiencies, pseudodementia. Now, confirmation, a complete diagnosis, a real diagnosis, is made only with an autopsy. Right, so, you can look on brain scans and see the deterioration, but the true diagnosis would be an autopsy. Okay, so you're gonna, of course, ID and make sure that that's what you rule out everything, and that's what the condition is. Suicide and aggression, assess the family's concerns, review their meds, make sure there's no neglect or abuse. What's their home environment like? Wandering, if they're aggressive, do they have sundowner syndrome, which we'll talk about. And of course, you're going to evaluate their cognitive functioning, see how the family members are coping, what resources they have. And then here's some nursing diagnoses. Of course, risk for injury, obviously impaired verbal communication, impaired memory, labile mood, but those are on table 18 too. Just make sure that when you have a diagnosis that your outcome matches the diagnosis. Okay? Okay, and then planning. First you have to ID their level of functioning. You can reduce stress by having a little bit understanding of the disease and establish realistic outcomes. And the nurse needs to take care of herself too. And then here's a functional dementia scale that's in your book if you want to look that over. There's a list of questions and then how they're rated. So they have counseling and communication techniques, health teaching and health promotion, community support. Sometimes they have it's like adult daycare for people who work and they're taking care of a family member, and interventions for home safety. Oh yes, here on the next page they mentioned the daycare center support groups, telephone helplines, Meals on Wheels. So now, as always with nursing, we pay attention to the safe environment, right? So that's table 18.8 on, I believe, page 287. So, of course, you would want to gradually restrict the use of the car. Sometimes they can go ahead and drive for a while. You watch for throw rugs that might trip them, things like that. They don't need a lot of stimulation, just like with anyone like schizophrenia. You want to keep it low stimuli. If they get verbally upset, you give support, but you try to change the topic because you really can't reason. It's good to label drawers in different rooms and the objects they use often. Of course, you want to supervise them if they smoked. One thing you can do for a safe environment, and I think we'll talk about that on the next slide, is to encourage activity during the day. Does anyone know why that would be?
They get tired at night. They're like a distraction to.
It can be, but I think I heard someone say it so they're tired at night. Why do we want them tired at night?
To sleep.
Right, limit wandering because of the sundowners that they can have at night. So there's some interventions here. Place a mattress on the floor like you might do a child, or use a bed monitor. They would definitely need a medical alert bracelet. It says if they're in the hospital, they could wear a brightly colored vest, locks on the doors, but also, I don't think it's on here, but you do want to encourage activity during the day, because that does help them to keep from, oh, it's on the next slide, here it is. Encourage physical activity during the day. As we said, that can help them to be more tired at night. It's not going to be foolproof, but it might be a help. And pictures and magazines, because if they've lost their reading ability, even children's books with nice pictures, and magazines with pictures. Activities that help with their large muscles, and the daycare centers have group activities. So be familiar with those. And then with communication, always identify yourself, even just like with the delirium, even if they don't know who you are, because there are snatches sometimes where they do know who people are. So identify yourself, call them by their name at each meeting, speak slowly, but use short, brief phrases, just like with the delirium. Face-to-face contact, like with delirium, and be close, 1 or 2 arms lengths away. So that's different than the schizophrenia too, because you don't want to be up in their face, close, but with these, with the delirium and the dementia, you do. Of course, if they were to get aggressive, then you wouldn't just keep maintaining in their face. Tactics. Okay, so more communication guidelines here. Focus on one piece of information at a time. Talk about the patients. Talk about familiar things to them. Okay, so if they're delusional, acknowledge their feelings, but reinforce reality. And you do not argue with them, or it says here, refute. So if this was to escalate, you wouldn't maintain, in this instance, face-to-face contact. So this would only frustrate them if you tried to correct them and explain. And have them wear their eyeglasses and hearing aid like the people with delirium. And it's a good idea to have clocks and calendars, a personal item with family pictures. And if the patient gets into an argument with another, separate them, and then you can always try to explain your intervention later. If they're aggressive, you just acknowledge, I know this is upsetting. So this just tells us that age alters the metabolism and elimination, and medications that they take might not be eliminated. So you would start low and go slow. We talked about that. No cure exists. But they have come up with some medications, and the most commonly used are the cholinesterase inhibitors. You want to be familiar with those. They don't cure, but they can prevent or delay the symptoms. So they're useful with mild to moderate. Once you get past that, they really aren't going to do much. So what they do is they prevent the acetylcholine from breaking down. So they help to stimulate the nicotinic receptors to release more acetylcholine. And here's a list here and you'll want to be familiar with these. So, diazepam is, which is Aricept, is a cholinesterase inhibitor. That's very commonly used. And then, they have a patch, Exelon. That's also for mild to moderate, but usually you can use it for more severe too. I don't know how well that would work. It prevents the breakdown of acetylcholine. And then there's Namenda. That sometimes can be used in conjunction with the Aricept. But you'll want to know which ones are in what class. So, and also be familiar that the cholinesterase inhibitors are the most common, but know which ones are cholinesterase inhibitors. Okay, so they could have coexisting depression, and sometimes they give SSRIs, which could be Wellbutrin, effects or Remeron that we talked about before. You really wouldn't want to use restraints. They're rarely indicated, to control disruptive behavior. So, what are we going to do about psychotic signs and symptoms then? Atypical antipsychotic meds that are used for behavioral symptoms, we know, I think you remember these, the risperidone, the olanzapine, and the Seroquel. None of those are approved for treating Alzheimer's. So even though they help with psychosis, the FDA came up with a black box warning saying that the treatment of behavioral disorder in elderly patients with dementia, if they're treated with atypical antipsychotic medication, it can worsen their cognitive impairment and even cause death. So that is important to know. So be sure you make a note of that, okay?
I'm sorry, you said the SSRIs can cause death if they use them? Is that what it was?
No, the psychotic.
Psychotic.
The SSRIs are better tolerated, but you have to remember too that they run the risk for oversedation because they're eliminating more slowly. Okay. Psychobiologic agents showing promise for the treatment of cognitive impairment associated with AD include what? A. Cholinesterase inhibitors. And which one is a common one? No.
Aricept.
Aricept, right. And know the generic name. Diazepam. Or how do we say it?
I know, right?
Okay. Nursing staff that care for patients who are cognitively impaired can develop burnout. Strategies to avoid the development of burnout include setting realistic patient goals, insulating yourself from the emotional involvement with patients, sedating your patients to promote rest and minimize catastrophic episodes, or encouraging the family to permit the use of restraints to promote patient safety. A, right. Okay, and there's some websites. Any questions about 18 before we move on? No? Okay, now we're going to talk about dying and grieving. So here's a slide, National Hospice and Palliative Care Organization. And the concept of these is compassion. Compassion is being with someone who's suffering. It's less of a feeling and more of something that's developed. And just hearing about the other suffering, and we can just be there for them. So something that's similar to compassion is sympathy, empathy, concern, kindness, humaneness, understanding, tenderheartedness. So this says, remember that compassion is developed throughout life, and we can grow in our abilities. So think of it as a practice or a habit of thought and action that connects us meaningfully with others. So I think the more you experience, the more compassion you probably have. That's a Ms. Levi. The more experiences you have, then you can relate to the other people and be compassionate. Okay. The object of death and the terms of grief are to discuss and differentiate between palliative care and hospice, and compare and contrast the objective, compare and contrast the terms loss, grief, mourning, and bereavement, which you will want to know. So hospice is a multidisciplinary team made up of physicians, nurse, chaplain, social worker, CNAs, volunteers, and bereavement counselors. All the medications and supplies are related to a terminal diagnosis, which is covered by Medicare. So hospice, most are cared for in a home. Sometimes they have short-term acute care, respite care for caregivers. Respite care is when the caregiver is getting burnt out and needs a break. So they can provide respite care. The patients are perceived to be fully living until they die. And their choices and preferences are incorporated into their care. And patient and family are considered the hospice unit, and they both can receive counseling and support. There's anticipatory grief and mourning. So basically it assists families in finding meaning and purpose at the end of life. So it helps with grief and mourning. And it helps to keep them comfortable. So with hospice, do you know, are there any new treatments or procedures done? No. That's the big difference between hospice and palliative care. Palliative care does a lot of the same things as hospice, but with palliative care, they might try new procedures or treatments, whereas hospice, they don't use any of that. If you do, then you're not considered a hospice patient anymore. And I do want to say, not all hospice is created equal. There are some great hospice, and there are some that, unfortunately, that are not. I've seen both. Unfortunately, I've seen the ones who aren't, but when they work like they're supposed to, it's wonderful. Okay, so palliative care grew out of hospice. With hospice, it doesn't mean you're dying right then, but your diagnosis would be you will not get better. So someone with CHF could be a hospice patient even though they might live 5 more years. So with hospice, it doesn't mean they're dying tomorrow or next week. But they do need to have a diagnosis that they will not get better. So any question between palliative and hospice? Okay, so with palliative care, they have individual choices and decisions. So they could decide that yes, they want to go ahead and try a new procedure. So this says electing hospice care is appropriate when the patient leaves the hospital or physician's office with the understanding that a cure is no longer possible. But many sophisticated medical and holistic interventions are still available for this phase of living. On the other hand, I have seen some hospice that people wanted to go ahead and use their own natural herbs, and they said, no, it's our way or the highway. So, unfortunately, like I said, it's not all created equal, but that's the way it should be. It should be that they have the option as long as they're not trying to cure themselves. So here's some myths about grief and mourning. Grief and mourning are the same experience. There's a predictable and orderly stage-like progression to grieving. It's best to move away from grief rather than toward it. And after the death of someone important to you, the goal is to get over it. And tears are an expression of weakness. Those are all myths. Those are all wrong. So there used to be stages of grief, but they've sort of gotten away from that, and now they've gone to terms. And these terms you'll want to know. You'll want to be familiar with these terms so that you'll be able to use those to know what part of grief someone might be in. And that's page 3, I believe it's 390. So loss, of course, it's a normal part of the human experience. And grief is individualized. So the response to a loss, it's perceived, real, or anticipated. So the 3 terms are anticipatory, number 1. It helps people recognize grief as part of living with a terminal prognosis. Disenfranchised is not socially sanctioned, openly acknowledged, or publicly mourned. And complicated is unresolved. So normal grief is uncomplicated. It's a normal progression. So there could be depressed mood, insomnia, anxiety, poor appetite, loss of interest, guilt that you couldn't have done more, dreams about the deceased, confusion, poor concentration. People may be in shock or denial depending on the situation, and they might isolate themselves. So that's normal grief. And then they might have spirituality that's either made stronger or weaker by the experience. So that's all normal grief, but depending on how long that lasts and what people do with it depends on these others. So anticipatory grief, it's a display of emotions such as anger or sadness, hurt, fear, or anxiety. From the moment the patient or family is diagnosed, they begin to experience a loss, but it doesn't make it any easier. So disenfranchised could be maybe when families aren't getting along. So in other words, the patient dies and another family member wasn't allowed to go to the funeral because the families didn't get along. suicides or HIV and just differences with people's temperament and beliefs. And then complicated grief is unresolved, and it occurs when individuals have difficulty coming to terms with the loss outside of the normal grief reaction. So basically, it impairs their ability to function. So an example of complicated might be they become, after a period of time, instead of moving on, say maybe after a year, there's no timeline, but they might be unkept, they look disheveled, they're reclusive, they're not able to work, versus just having difficulty concentrating at work. So that would be normal grief. You know, you having a little difficulty concentrating at work because of the grief, but with complicated grief, you can't work at all. And you can't control your crying. You know, you still might cry some with the normal grief, but with a complicated, you can't quit crying. You're just constant tears. Anybody have any questions about those different types? No? Okay, so be familiar with those. And mourning, that's more of a ritual, and bereavement is a symbol. That's in your slide too. So the theory here, Eric Lindman termed the phrase grief work, where Elizabeth Kubler-Ross had the stages of bereavement in an orderly sequence. So they, like I was saying, they used to describe it as recovery of how a person adjusts, but they found out each person has their own unique timeline and the way they handle it. So a common phenomena is in grieving. They could have shock and disbelief, denial, especially if the death was unexpected, guilt or anger. Denial is usually the first response. And then there's 4 tasks of mourning: accept the reality, process the pain, adjust to a world without the deceased, and find a connection with the deceased in going about a new life. So what we want to look at here is the communication skills and the patient and family-centered goals. So, according to your book, you must be able to address your own fears and own mortality before experiencing care for someone who's dying. So that would go with nurses too. So mainly, you pay attention when you're working with someone, or even a family member, or say you're a hospice worker, you just pay attention and listen. You don't go into talking about you. If they're saying, oh, I missed this and that, you don't go into, oh, I know, when my cousin passed away, you just acknowledge what they're saying. And then there's advanced care planning, which would be advanced directives. Now, and this is all on page 395. So advanced care directives, don't confuse that with DNR only, okay? So it could be in advanced directives, but know that advanced care directives could be a living will or a medical power of attorney, where that lets people make decisions for you if you can't make your own, as far as treatments go, testing procedures, comfort care. So just know that it's not only DNR, okay? And as far as communicating, it's hard to teach the communication. So basically remember that you don't talk about yourself. Listen and be with them. Just be with them in the moment. So it's good if you read over in your book some of the communication sayings for all the chapters, not just this chapter. How you would answer someone, because they have good examples. Okay, so objectives for those who grieve. So it says here, explain the interventions you would take to help grief-stricken caregivers in the following areas. Helping the bereaved caregivers come to terms with their feelings, helping people say goodbye, helping families maintain hope, and establish a therapeutic presence. So basically, to sum this up, what you need to take home from this is it's best to allow the families to participate. Don't just say, oh, we're here to take over, you just sit in the chair. It's best to let the families be involved and participate. Okay, and on page 400, there's a table, 25-4, with therapeutic techniques. And this is where you could read over some therapeutic communication. Just remember, your therapeutic answers is not what makes sense to you or your communication. It's what makes sense what the book says, okay? So sometimes you might want to tell someone something, but don't worry about if it's making sense to you. Worry about what the book says, okay?
She was saying it's best to allow the family to
25-4.
involve and participate.
So it includes talking about feelings, letting them talk about feelings. They might want to do journaling. And it's their feelings, not yours. Okay, so here's some examples. If you sense a fear of the future, it must be scary to go through this. When the bereaved seems confused, this can be a confusing time. Painful situation. This must be very difficult for you. So the more you see those, the more you'll know. So in other words, you don't say, oh, I know it's painful because I remember when, no, it's not you, it's them. And helping them say goodbye. Here's some other examples. You can encourage the family to tell their loved ones, I forgive you, please forgive me if there was any problems, I love you, I know you love me. So look over all those communication therapeutic techniques. And then hope. You want the families to still have hope. So don't think of hope as a form of denial or reality. So they need to let the loved one know that they will be missed. And here's therapeutic presence. That goes along with communication. So just being there. You're not there to fix. You're there to be a presence. So this talks about when survivors of terminally ill loved ones describe what was the most helpful to them, high on the list of the presence of people who could just be there. That was high on their list. They preferred interventions, not simply someone just to be able to do something for them. So it's effective presence. And along with this, You need to, as I said before, let the family participate in the final days. Notice what the patient says or doesn't say. And at this point, therapeutic touch would be okay, unlike schizophrenia or other areas that we talked about before where we don't touch. Therapeutic touch is usually fine in these instances. So here's your presence, just being there for someone, not trying to fix, sometimes just listening. And then self-care for nurses and staff. Staff and nurses can get desensitized or numb. So they sometimes need to mourn the person they cared for, even though it might not have been a family member. They might have become very fond of them. So now, assessment of complicated grief. On page 398, acute grief can exacerbate and not get resolved, and then that does become complicated. So especially if the person already has a history of depression, substance abuse, PTSD, it can quickly become complicated grieving and cause prolonged extreme depression. So disturbances in mood are sometimes associated with changes in the body related to depression. So they could have electrolyte disturbances from not eating, nervous system alterations, faulty regulation of their autonomic nervous system. So especially if they're depressed or they have other mental disorder. So with these people, if you were to hear someone say, "I just can't go on anymore. I don't want to. I just want to die too." What would you always want to do? Right, assess for the potential for suicide. So remember that. So risks for the complicated grieving, we talked about if they already have past problems, guilt, thoughts that they would be better off dead if they can't be with a deceased person. And nursing diagnoses of grieving, that's a given. Complicated grieving, risk for complicated grieving, ineffective coping, disturbed thought processes, you can read over these. Just know that your outcome needs to match the diagnosis. And here's a question. Grief is best described as a normal response to a significant loss, mild to moderate severe mood disorder, display of feelings associated with death, denial of the reality of the loss of a significant person, object, or state of being. A? Yes, A. A normal response to a significant loss. Okay, so outcomes. On page 399 are expected outcomes. And that there's no special timeline. It's more of what the people say and how they transform later that it makes it become complicated. So here are some outcomes. Can tolerate intense emotions, reports decreased preoccupation with the loss, tends to previous responsibilities. In other words, they resume their roles before, and you want them to do that. And they remember the positive and negative aspects of the deceased. But also a big one here is express positive expectations about the future. That is a great outcome because it doesn't mean they're over the death, but they're beginning to see some hope or expectations that things will get better in their future. So be familiar with those. Planning. it doesn't have to be a death. There can even be grief with like you've lost an arm or a leg. And there's referral support groups. There's grief counseling for people who have lost someone to death or a loss of a limb, mastectomy. There's psychotherapy for this. If people are not able to come to terms with their grief, education, psychotherapy. Sometimes people, they have you journal, and whoops. So basically, you take the time to grieve. You don't rush through it. You don't say, well, it's been 2 weeks now, or you don't tell someone it's been 2 weeks, you should be getting better by now. So sometimes rituals like funerals and viewings are good for people. Sometimes maybe not so good for others. If not feeling better within a few weeks for a few hours each day, tell your physician or practitioner. So they're not really putting a timeline, but in other words, you should start to have a little bit of improvement. It doesn't mean you're over it. Okay? Any questions about 25 before we take a break? Okay. And today, during the study lab, I'm going to go over I have a practice exam, like I usually put up. And if there's any problems in there where we can sort of try to interpret, or anybody has questions as to how to interpret those better, because I think sometimes everybody has the knowledge, it's just in putting it into those problems. If there's any in there like that, we can go over that, okay? So let's take everyone's so quiet today. That's great. Are you falling asleep? Okay. They're the ones that are at most risk for emotional and physical illness. So if they don't have support, and if they come across, trauma or anything like that, without guidance and support, they're at even bigger risk. So children and youth with a high degree of resilience have usually had available resources, good parenting, or another mentoring figure, and they're neurologically less vulnerable to stress. So children and adolescents that grow up with hardships, of course, they're going to be at more risk for emotional and physical illness. And as I stated before on the other slide, am I on? Okay, that is the slide I was talking about. I never changed it over. Okay, so there they go. They have more. They have help. They have people helping them, counseling them, good parenting, and mentoring. So the first symptoms are likely to occur in early childhood or early adolescence. So there's about a 21% prevalence of psychiatric disorders in children between 9 to 21. So only about a fifth of all of the young people who need mental health care will receive it. Suicide is the third leading cause of death in 15 to 24-year-olds. And it's a frequent complication of untreated mental illness. So children with mental illness often meet the criteria for more than one diagnostic category. So they might have juvenile onset bipolar, also have ADD or ADHD. So the theory here is genetic, biochemical, environmental, and their resiliency pertaining to if they've had support, parenting, mentoring. So under genetic factors, they could just sort of have a genetic temperament. 30 to 40% of children with ADHD have a family member with the disorder. But then I kind of wonder if the family member has the disorder, are they learning that behavior? I mean, it's kind of a fine line, but they do think it might be genetic. It could be autism, bipolar, schizophrenia. Biochemical would be norepinephrine and serotonin levels in children also. Hyperactive impulsivity, that would have to do with dopamine. And then, of course, environmental factors. Were they abused? Did they come under a lot of traumatic events? So their mental status assessment is similar to that of adults, although they do take in the developmental level. That would be considered that. And then the child's current maturational level compared to their chronicle age. Is it developing or lagging? And there's a Denver 2 development screening test for infants and children up to 6. So the same way you would collect other data and assessment by interviewing them, testing, observing, interacting with them. You can also get histories from parents and caregivers, teachers. You can question them about their life, their home life in school. You can let them know they're free to describe any current problems. Sometimes with children, it's games, drawings, and puppets and play to get information. And it could be observations too from caregivers, siblings, and teachers, for instance. So the child and adolescent mental status assessment, you look at their appearance, their activity level. Do they have tics? Are they sucking their thumb when they're 12? We hope not. Their speech, is it just like you would assess other adults, but you would assess it for their age group. And their affect, they have affect too, just like adults. And how do they relate? Do they cast their eyes down when they're talking, or they look at you? How are they relating to the interviewer? Their memory, creativity, humor, solving problems. You check their orientation too for their level of ability. And then characteristics of child's play is age appropriate, could be imagination, themes of play. So now here, when you have neurodevelopmental disorders, it used to be called mental retardation, and then I believe it was mentally handicapped. Now it's intellectual disability, ID. So that's the term now, ID, and it can be mild, moderate, severe, or profound. And you are going to want to know all those different types. So if your PowerPoints say the intelligent IQ tests are no longer defined level of impairment. And impairment could be inherited, like Tay-Sachs or the Fragile X syndrome, Down syndrome, fetal alcohol syndrome, fetal malnutrition, hypoxia, infections, and then other trauma at birth. About 0.6 to 2% of the population are affected. So we're going to talk about mild, moderate, severe, and profound, as you thought we probably would. Okay. So let me go back to that slide. So mild, they have about 85% development. So they have minimal sensory motor impairment. A lot of times they're not distinguishable from other children except for the IQ range. And then there's moderate. So with moderate, their communication, social, and academic skills are slow. Elementary school level with reading, they will probably progress from first to third grade level. And they might be able to perform their activities of daily living with assistance. So that would be moderate. Severe, their development is delayed. They can only say single word phrases. They require assistance with ADLs. They can perform simple tasks, but they would require supervised living environment as they got older. And then there's profound. They're nonverbal, they don't read, tend to have sensory and physical impairments. So, in other words, moderate. With moderate, they might be able, when they're older, have a job with support. So, in other words, an example of that, they might be a bagger at Publix, say. So, that would be an example of moderate. So they can still, moderate is what it is. It's kind of in the middle. They're not profound. They can talk with you and discuss and do a job with some assistance. So be familiar with those. Now, those are on page 407. So sometimes people would say, they say, well, they don't look like there's anything wrong with them, or parents might wonder, well, they seem fine. So it's important to note that the more severe the developmental disorder, the more physical abnormalities there'll be, the more it shows. Okay, so keep that in mind. So a diagnosis is made. They have the DSM-5 domains to determine the severity. The IQ range is no longer used, it says. So they would determine this by what they're able to do and not do. So risk factors for this are age, mother and father, exposure to substances, diagnostic tools would be blood and DNA tests, brain scans, but then it says IQ testing. So they can use that, but it's not definitive apparently. So there's individual and family counseling, appropriate schooling, and then the educational, individualized educational plan. And the IEPs, they use those also with gifted children too. So it's not, the IEPs are not only for ID children. Okay, so communication disorders. They might have speech sound disorders. They might stutter, have a social communication disorder. So then they get referred to a speech therapist, school psychologist. Speech therapy is usually for several years. That's usually provided in public school or, private setting. And as counseling for self-esteem issues. So the stuttering, though, is usually before age 6. This is a Miss Levi side note here. Just because a child stutters doesn't mean that they have, they're mentally slow or have ID. It could be nerves. They could, when they're under stress, they may stutter when they don't stutter at other times. And also with a lisp, sometimes it's a frenulum. They're tied, and that can cause a lisp sometimes. So it's not always that. So then we're going to get on to autism. And autism has its levels, and you'll want to know the levels. They're on page 408. So there's autism spectrum disorders. It used to be classified as autism, Asperger's, and pervasive developmental disorder. Now it all comes under autism spectrum. However, this is another Miss Levi aside here. Asperger's, they are highly intelligent. So sometimes, and there's different forms, but a lot of times they have problems communicating socially, but they're extremely gifted, usually. So I just want to make that little note there. So sometimes they have deficits with, like I was saying, social and communication. They can't interact. Sometimes they have repetitive patterns of behavior. They might have tics. So there's level 1, 2, and 3. And so with those, the repetitive behaviors, they might twirl their hair. Remember the fellow with schizophrenia that continually took his hair and twirled? That would be an example. Or they might, just, rock back and forth. And sometimes they just don't really want to socially interact. So with level 1, there's a noticeable social deficit, but the language and speech are normal. They might have difficulty switching between activities. They might get focused and struggle, but yet they struggle with organization and planning, but they don't like to be interrupted. They focus on one thing at a time. And then level 2, there's noticeable deficit in verbal and nonverbal social and communication skills. They might have the repetitive behaviors that are obvious, and a change of routine causes stress. Level 3, the social deficits are severe, and communication is very, very limited. They may be nonverbal at all, or speak a few words, make odd noises, echo one sentence over and over, and have more of the repetitive behaviors. Sometimes, and I've seen this, where let's say level 1 or even maybe level 2, they at home, once they get older, they can sort of hide it at home if they are aware, but they hide it when they're out, but when they're home, it's sort of like they let their hair down. It just depends on their level of functioning. So to come under that and be diagnosed, they have to demonstrate 2 or more of the repetitive speech, motor movements, echolalia, or repetitive use of objects, excessive adherence to routines, rituals, and resistant to change, fixated interests that are abnormal in intensity. Like they might spend all day, a toddler, wanting to just look at the dishwasher and mess with everything inside the dishwasher. It's just an example. They might be hypo or hyper reactive. They can have sensory issues. They might be indifferent or be more sensitive to pain or heat. Sometimes the autistic or even higher functioning, they're extremely higher functioning, which used to be called Asperger's, they have sensory problems with clothes, like labels, tags in their shirts, touching their back of their necks. And there can be varying degrees. This can be slight or exaggerated. Socks with a seam around the toes. And sometimes as they grow, they kind of work out of that unless they are really high level. So they might not like tight underwear, things like that. And then the deficits are social and emotional. They have a hard time with give and take, back with people, verbal, nonverbal, we talked about that. And they have a hard time developing and maintaining relationships. And then now for the assessment and diagnosis. I believe that's on 408. Of course, you observe for deficits, bonding with parents, dislike of cuddling sometimes, poor eye contact, lack of communication, and this can sometimes, you might see rigid routines and rituals that they don't want to give up. It's usually diagnosed as when they're toddlers, and 2/3 have a comorbid mental condition. So, the plan for treating this would be behavioral management, because you do need to set limits, and remember that. Early intervention, the proper education and school-based plan, joint therapy, but there's also medications. So, you'll want to be familiar with those. Risperidone is used for aggression or self-harm. And what type of medication is risperidone? Risperdal? Antipsychotic. So an antipsychotic is used for aggression and self-harm. For obsessive symptoms or anxiousness, they use an SSRI or beta blocker. So that would be for anxiety. So review those med classes and know which one's used for what. So know if it's an antipsychotic and what those are. And, to me, that should be the last resort, medications. So then there's attention deficit hyperactivity disorder. Used to be ADD. It's assessed as mild, moderate, or severe. And symptoms usually are prior to age 12. Problems with concentration, focus, they're easily distracted, appear not to listen, have a hard time following through, have a hard time with time management, and that's diagnosed with a Vanderbilt assessment scale, but it's also includes teacher and parent too, involvement. So the children may squirm or fidget, leave their seats, climb, talk incessantly, interrupt, but a lot of this is normal childhood behavior too. So everybody should keep that in mind. Children don't like to sit still all day. So just because they're fidgety doesn't mean they're ADHD. Okay, so with interventions here, on page 409, behavior modification therapy, parent training, and school accommodations are interventions, along with pharmacologic agents that can help with the inattention and behavior. So there is Strattera, which is a non-stimulant, and Ritalin, Adderall, Vyvanse, they are stimulants. So, according to your book, children who are treated with medications are less likely to use illicit drugs later in life because their mental health symptoms have been addressed. So, but what you want to take home from this slide is to sum all this up, to sum these interventions up. It's a combination of behavior therapy, parent intervention, and the proper school setting and help at school. Any questions there? So there's no one way there. Should include all three. So then there's specific learning disorders, which would be dyslexia, dyscalculia, which is problems with math. Dyslexia, it's a reading disorder. I think probably people are familiar with that. They can have a hard time reading because things look backwards. And then with math, they have a hard time comprehending math. These are more common in males than females. And it's a big reason for dropping out of school if not caught early and helped. So then there's motor disorders. Developmental coordination disorder would be delayed motor skills, clumsiness, slowness, difficulty with handwriting and riding a bike, and Tourette's. Tourette's is a motor and tic disorder. It starts in early childhood. It can range from mild to severe, and it can be embarrassing. And it is quite sad because they don't really have control. So I don't know if you've ever seen any movies or video clips. I should have brought one up on someone with Tourette's. Sometimes they cuss and they just can't stop it. Sometimes it's a verbal problem where and you would think, how can they not? But it just comes out. So then the tics, they can't stop the tics. Now, I have seen children, and especially when they get to be early adolescents, if they're under stress, sometimes they'll have tics, but it's not really true Tourette's. So that could be a common, like maybe like tics with the eyes, but it's along with coming into puberty if they have problems at home or if they have any stress going on. So don't confuse that with Tourette's. So what is very interesting here, and this is on page 410, you're going to want to take note of this. There is now a new intervention called Comprehensive Behavioral Intervention for Tics, CBIT. And it's a new treatment that tries to work on habit reversal, insight education, and relaxation, and it's been shown to reduce tics. And sometimes propranolol is used, and propranolol is what class? Beta blocker, right. And it has a relaxing effect. So sometimes it can be used for tremor and haloperidol, and that's a what type? Antipsychotic, can be effective in decreasing tics. But it's a great advancement, the CBIT. So you want to know about CBIT on page 410. Okay, now schizophrenia and psychotic disorders. Generally, schizophrenia starts late teens, early 30s, but it is not unheard of to be in children. And we all know what that is: hallucinations, paranoia, delusional, and bizarre thinking. The diagnosis is made by a psychiatrist or psychiatric nurse, just like with adults. And it says here it's rare in childhood, but it may occur in children, and sometimes it's misdiagnosed as autism. So bipolar and related disorders. Yes, children can have bipolar. And it usually shows up in late teens. So mood lability, alternating from compression to elated states, being manic. So their speech, they might have that rapid speech too. They may have their manic and then their lower episodes. It may show as depression. They may be crying a lot and isolate themselves. But the mean age for the first manic episode, hypomanic and manic episode, or depressive is usually 18 to 20, but it's not unheard of that it would be in the teens. Okay, so I think it's 411. There's a table in chapter 23 that talks about this scale, sad person scale. So let's say you had a child that said, I don't have anything to look forward to. There's nothing for me to look forward to in my life. What would you want to do? Right, and you could use this sad person scale. Okay, so then depressive disorders, disruptive mood dysregulation disorder. That has to be diagnosed in childhood, and it starts before age 10. So they might have outbursts, more than just an occasional temper tantrum, persistent irritability, and angry most of the day. They have inconsistent development. So you assess, diagnose, and implement. So you look for signs of depression, anger, isolation, change in dress and friends, poor school performance, and possible self-harm. So yes, of course, that wasn't a phone, was it?
No.
So of course, if you were to see these things, anger, isolation, possible self-harm, poor school performance, all this change in dress and friends, you would want to assess for suicide and use that sad persons. They would need, of course, supportive therapy, behavior modification, family support, and protection. And assess also, you don't have to just assess for suicide, but if you saw any of those, you would want to assess for depression too. Because you don't know they're depressed yet, so assess for that, seeing those. Then there's anxiety disorders. And there's 3 different ones, and guess what? You all need to know these. So I believe they're on page 411. So these are really the same as adult except for separation anxiety. So separation anxiety is when it's developmentally inappropriate for them to be separated from the person they're most attached to. So your book says the symptoms are normal up to age 1, but I find that, even a child going to preschool could have separation anxiety, but it's when it becomes beyond just they get over it once mom leaves or dad leaves or sister leaves or whatever, leaves them there. They can't get past that. So, it's when it disrupts their normal social life, their activities of daily living, and their education is when it's an issue. Or if you were to have separation anxiety when you were 12. Okay, so then there's selective mutism, a failure to speak in situations when speaking is expected, but they can speak at other times, and phobias. So that could be being afraid of animals, monsters, clowns, but again, it's when it's not age appropriate. It gets beyond the age that would be appropriate. So know about those. And then, let's see. Any question on those? So read about those and know the difference in those. So assessment, diagnosis, and implementation. The assessment tools, there's the Spence Children's Anxiety Scale and the Hamilton Anxiety Scale. There's supportive therapy, cognitive behavioral therapy, which is CBT, family therapy, relaxation, guided imagery, children's books. So let's say you had a child who was having separation anxiety. You could get a book about a child having separation anxiety and how they gradually overcame that and started leaving mom and dad. And then there's, of course, they want to medicate, SSRIs, the antidepressants, beta blockers, or antihistamines. So, What are antipsychotics used for in children again? Aggression and self-harm. Right, right. And SSRIs are used for anxiety, right. So now here's little Max. So you're a community health nurse. Janice, 28 years of age, asked you how to manage your 7-year-old son. His name, that's Max. When she drops him off at daycare each morning, he screams and is terrified of being left behind. Both the parent and child end up traumatized and exhausted. So, what questions would you ask her? How would you answer her? And what would you teach her? Now it says, while viewing the next slide, answer the following, but there's no answer there. So, what questions might you ask her? Ask the mom.
How the child actually dropped them off at a family or friend?
Right, exactly. How do they act elsewhere? Is it just, then is it something going on at school? Or are they that way all the time? Are they always clingy and fearful? Are they nail biters, acting anxious? So then as far as teaching her, you'd want to refer, if it was everywhere and he was past the age where he should be doing that, then you could refer for family therapy. But what type of therapy would be good for children? Do you know?
Cognitive, behavioral therapy.
Right, and do you know how they would go about those behavioral therapies? Would they sit there and, like they would an adult? Right. There might be play therapy, drawing, and you'll want to know about these. Play, drawing, games. Would you ever use any harsh tactics? Like, would you do the ECT on a child? No. But you could do guided imagery, books, play therapy, drawing, games for therapy, and then, of course, medications. Now, I do want to say, this is a Miss Levi thing, it depends on the child, too. They could have legitimate reasons for anxiety like that. In other words, especially if they're real intelligent for their age. When my son was 4, it was when Ted Bundy was murdering college students here in Florida. Well, all of a sudden my son didn't want to go to preschool. And he was fine until then. He would, no, pitch a fit. And we thinking, what's going on at school? Come to find out, in talking with him, he was afraid to leave during the day because he heard that on the news about the killings. So it was because he was afraid for me at home. So that was just sometimes it can be things like that, that doesn't mean they really have a mental disorder. Maybe he did, I don't know. After they caught Ted, he was fine. Okay, now, and then there's obsessive compulsive and related disorders. There's trichotillomania. That's the twisting and pulling of the hair like we saw the guy in the video. Just continually worrying around his hair. I thought he's going to have a bald spot there. Excoriation, they might pick at their skin, pick it until they even have sores. So then you assess and diagnose. The trichotillomania is more prevalent in females, about 1 to 2%, and the excoriation is too. So So for those that use SNRIs, SSRIs, antipsychotics, and then there's trauma and stress-related disorders. There's a reactive attachment, where there's a consistent pattern of inhibited, emotionally withdrawn behavior, and the child really doesn't want any comfort for that. So, they're fearful and they're not social. And that a lot of times is caused by their environment, inconsistent care, being switched from one foster care to another, or being bounced from one relative to another. And then trauma and stress-related disorders. So again, you're going to assess, because it can resemble autism or depression or disruptive mood regulation disorder. So if you find out it's been trauma, so here's that therapy again. The therapy you're going to want to be familiar with. Family therapy, books, letting them draw, and you relate it to the child's situation. So just know in general that and there's dissociative disorders where it might be a result of abuse or trauma, where they just withdraw, and you want to check for abuse. So to sum up all those, in general, good therapy for children would be play therapy, drawing, games, books, but not any harsh therapy like the electric convulsive or anything. Okay, somatic related disorders. So you remember what somatic symptoms are? They feel like they have stomach aches and problems that they can't find any known cause. So that could be headaches, stomach aches, fatigue, often going to the school nurse. So the underlying cause needs to be addressed. Find out what's going on in the family, what's going on at school. And then there's feeding and eating disorders. There's pica, and that's eating substances that are not real food, like continually chewing ice. Ice, dirt. Rumination disorder. Repeated regurgitation of food, which is then rechewed, re-swallowed, and spit out. And avoided restrictive food intake, where it's failure to meet nutritional or energy needs, but it's not really anorexia. Okay, and then with those, therapy for them, family support, monitor their weight and nutrition, again, the medications. And then there's elimination disorders, enuresis. So they might wet the bed at night and during the day, or both. It's normal up till age 5. And there's encopresis. That's repeated passage of feces in inappropriate places. In other words, they're pooping in their clothes and on the floor. Now this could be normal up until age 4. So there's also, under encopresis, there is non-retentive and retentive. So retentive causes constipation, so they might hold it instead of go, and then that can cause megacolon. But there's non-retentive, and that is where a child refuses to poop in the toilet, and they're not constipated. And I know about that one too. My son's going to kill me if he finds out. If he ever finds out that I'm telling these things. But there is, this is just an aside because it might be interesting. Okay, so the non-retentive. My son was
potty trained. He'd pee, he didn't go in his diaper or anything. But he would tell me, and he'd go around in his little pull-ups. Not pull-ups back then, they didn't have them, but you know, they had like little potty panties. And you all may not care a hoot about this, but so he'd go around in his little potty panties and he'd say, I need my diaper. I want my diaper. I need my diaper. He wanted me to put his diaper on, and then he'd stand and poop in his diaper. So when the next pediatrician visit, I told the pediatrician, and he said, uh-huh. Mm-hmm. He said, you just keep giving him that diaper. I said, really? He said, yeah, because that's the one thing he can control right now. So just let him do that, and then over time, believe me, he's not going to ask for his diaper later when he's bigger. Well, he says, don't make a big deal of it. Here's your diaper. So we were on vacation, and we're in the car, and he goes, I need my diaper. I need my diaper. So we stop at this motel parking lot, and I put the diaper on, and he gets out, and he stands up, and he goes, and my husband said, it's like walking a dead dog. This is ridiculous. But anyway, that might have been boring, but that's an example of non-retentive. It didn't last long because he got tired of it. I did too. Okay, so elimination disorders, avoid shaming, encopresis, gastroenterologist may be needed if if it becomes a megacolon or there truly is a physical problem, but take a positive approach. And which child is most likely to benefit from CBIT? An 8-year-old boy with enuresis, a 14-year-old girl with pica, a 12-year-old boy with Tourette's, or a 17-year-old boy with obsessive-compulsive disorder? Right, because that's the comprehensive behavioral intervention that is new. Very good. So there's sleep-wake disorders. Most common is sleepwalking, night terrors, and nightmares. So soothing music, books, night lights, books again for therapy, books about the fears and everything of at night, relaxation, guided imagery, a regular sleep schedule, scheduled wakenings 15 minutes before usual. At night, incident can help. Scheduled wakenings 15 minutes before usual night incident can help. I guess they're saying wake them up before it happens. But sometimes that the nighttime fears that can go along when they're going through that separation anxiety time. And sexual dysfunction. There's gender dysphoria, feeling you're in the wrong gender body. Adolescents with pain and arousal of sexual dysfunction. You would go to support therapy in a non-shaming way to a therapist. And then there's oppositional defiant disorder, ODD. Angry mood, defiant and headstrong. Now, children are like that anyway, but this goes beyond. This is persistent and frequent. So, losing their temper frequently, easily annoyed, angry, argues with authority figures, defies rules, deliberately annoys others, blames others for their mistakes, and conduct disorder. So this can be seen as early as 2 years old, but can end up to be ODD. So they're physically aggressive, poor peer relationships, no concern for others, they really don't have guilt or remorse. And then adolescent onset conduct disorder, they act out with a peer group, end up with early onset sexual behaviors, drinking, substance abuse. That would be bullies, intimidating others, initiating fights. So sometimes they have deficits, cognitive deficits, psychosocial and moral development, and it results in these behaviors. And a lot of it depends on the parent-child quality relationship, and how the parents handle it, the parents' understanding of growth and development. A lot of times these behaviors are a result of unstable home environment. So 30% of, I already went over that slide, 30% of the children with ODD end up with conduct disorder. And it's the precursor to, what do these children sound like? It sounds like a younger form of the antisocial personality. Remember, antisocial isn't that they're antisocial with people. It's like the Ted Bundy type. Hate to pick on Ted today, but he was, I guess, first thing that came to my mind. So substance abuse and addictive disorders, 9% of 8th graders and 37.4% of 12th graders will use alcohol in a month. 27.2% of high school students will use illicit drugs within the past year. Now the risk factor is at their age group, I would think who they're associating with. Incomplete frontal lobe development can affect their judgment and impulse control. Now, neurocognitive disorders. Personality disorders, they must be present for more than 1 year if diagnosed before age 18. And the antisocial personality disorder cannot be diagnosed before age 18. Now this one, paraphilic disorder. Your book calls it the pedophilic, I believe, but they're the same thing. So paraphilic is they have recurrent, intense sexual fantasies, urges, or behaviors involving sexual activity with other prepubescent children, a child or children. They're at least 16 years old and at least 5 years older than the child. And that's a paraphilic disorder. So, there's paraphilias. Now this is just my own telling, I don't think this is in your book. There's paraphilias, they're preoccupied with non-conventional sex behavior, but it's not harming anyone. It's just their thing. But when they're paraphilic, it's defined as one that's harming other people, children, animals, things like that. So be familiar with paraphilic. So assessment, diagnosis, and implementation of the paraphilic disorder. Of course, you're going to ask questions relating to victim or perpetrator. The child might act, whoever has been the victim, might act sexually precocious, or be secretive or fearful around a child or adult. So, if you know of either a victim or a perpetrator, or you suspect, what are you going to do? You would report them to Child Protective Services. And I believe that's in your book. So be familiar with that. You wouldn't just say, oh, children will be children. Okay, and some other conditions that might require clinical attention. Oh, that was the slide I just told you about. Sorry, I didn't flip it over. That CPS is the Child Protective Services. So other conditions, abuse and neglect, educational and occupational problems, housing, economical problems. They can all cause these problems related to crime. Okay, now here are these therapeutic modalities that we talked about. Remember the play? So there's dramatic play, movement, dance, music therapy, recreational therapy, therapeutic drawing, family involvement in all this, group therapy, behavior modification, mood therapy, therapeutic games, therapeutic holding, removal, and restraint. So, but basically you want to be concerned with the ones that are going to be play therapy, reading, guided imagery, drawing, things like that, music. So, here's a question. An emergency department nurse is assessing a 16-year-old adolescent who has been inhaling aerosol paint. In this assessment, which topic must be explored that is different from an assessment in the adult? Presence of distorted perceptions of invincibility, presence of possible ideas about hurting self or risking death, circumstances that contribute to the individual's instance of substance abuse, investigation of precursor feelings such as depression, anger, guilt, and rejection. Now, this is, before we go on, this is a good example of some exam questions where you have to go back and reread the question. Which topic must be explored that is different from such an assessment in the adult? So even though you might not have ever heard of this before, you might can figure it out by eliminating some of these. If it was an adult, would you assess about hurting themselves and risk of death? Yeah. Circumstances that contribute to the individual's use of substance abuse? Yep. Would you investigate feelings of depression, anger, guilt, and rejection? So even though you've never seen that before, where does that leave you? A. Right. A presence of distorted perceptions of invincibility. It says this age group does not have full development of the frontal lobe affecting judgment and impulse control, and often feels invincible. Not that they all do, but they can. Okay? Any questions? All right. So, do you want to take a break or go into some study that?